Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Kevin. How are you doing today, Kevin?
Doing great. How are you, Dennis?
I'm doing very good. And what I'd really like to talk to you about is kind of a deep dive on ketamine and what it is and what it's used for and what does it do. And I think a lot of guys, they know the basics, but they haven't really dug into it.
Yeah, so ketamine, it's a NMDA receptor antagonist. And when we talk about, pharmacodynamics, what does the drug do to the body? Ketamine has, and it's still, the science isn't completely settled on a lot of the things that ketamine does do to the body, but we all know that it can cause some profound analgesia in certain dosing. And then in higher doses, it can, cause a dissociative type of anesthetic. And just I know this is one of the questions you originally asked, so I think we could just, when we talk about a dissociative anesthetic and how they've kind of termed this is there's EEG evidence. And what they've done is they can see that there's dissociation between the thalamocortical and limbic systems. So those two systems just become disassociated and you become into kind of this kind of catatonic state. So your eyes remain open. You have that nice nystagmus. There might even be varying movements of but nothing that makes sense to what's going on. So like if you're just doing a purely ketamine anesthetic, patients might move, but it's not purposeful or they're not trying to get away from the surgical stimulus, if that kind of makes any sense. So as far as the dynamic portion of it, that's about the best thing I could find when we talk about how ketamine creates this disassociation. So what I usually tell people, and so people are like, hey, how does this work? I'm just like, it essentially just a very, very basic way to think about it. It just disconnects the top half of your brain from the bottom half of your brain and essentially from the rest of your body. So there's still thoughts being and memories potentially being formed in the upper portion of your brain. And that's where I think people can remember their kind of the hallucinations that they've had or that feeling of they're floating. It's because they're just not receiving that information from the rest of their body that they're actually on the ground. Like they have no sense of what gravity is. So that's kind of the disassociative portion of ketamine. So also, kind of the pharmacodynamics that we should talk about because our European or our some of our colleagues in the European nations, they have what's purely an S-ketamine. And I think it's been approved now we've got some intranasal S-ketamine approved for depression. So the ketamine that we are all carrying is a racemic mixture, and it's the S-ketamine and the R-ketamine. And it's the S-ketamine that produces all the things that we want. And then it's typically, the way I think about it, it's the R-ketamine that produces all the stuff that we don't want. So S-ketamine is a more intense analgesic. It has a more rapid metabolism. Therefore, it recovers quicker. It's less salivation and also some lower emergence reactions than the R-ketamine. So it'd be really nice if we could get our hands on S-ketamine. A lot of our potential issues that we have with ketamine, we would not have to deal with. But unfortunately, it's what we got. So, and I don't know if the science is settled on this either, because I've in some of the the anesthetic textbooks that I read or the journals that I read versus some of the purely pharmacology textbooks or journals is like, how does ketamine create that the sympathetic response. And what most of the things I found is that once the norepinephrine, which is the major neurotransmitter for the sympathetic nervous system, also epinephrine, once we get a big sympathetic surge, that it somehow creates a scenario where it does not get reuptake back into those neurons. So typically norepinephrine will be, has just through the mechanism of action, it just gets taken up back into the presynaptic neurons, where ketamine stops that. So it just creates more of a sympathetic surge because you have more catecholamines in those attaching to the postganglionic sympathetic nerve endings. It's almost, and this is what one of the anesthetic textbooks said, it's almost like a cocaine-like effect, because cocaine, that's what it does. It prevents the reuptake of norepinephrine. So that's kind of one of the other things that this drug does to the body. Mm-hmm. So if we're sticking with the kind of the pharmacodynamics, the analgesic portion of this, one of the bigger analgesic portions of this, it takes place in the dorsal horn of the spinal cord. And in the dorsal horn of the spinal cord, glutamate receptors will fire, and they can create over time chronic pain. And then that's where ketamine can come in and help potentially decrease like a chronic pain that can happen down the road. So it also, my last peek at reading about ketamine, it also works at the mu receptors for opioids. It works at muscarinic receptors. It's the dynamics of this it's still emerging as far as where it all works, but it seems to be working just about everywhere in the body. But obviously the biggest effects that we see are the NMDA receptors. Is that kind of a good way to look at this?
Yep, I understood absolutely everything that you said.
All right.
But,
well, and then so it's it's hard because I read my anesthetic textbooks, and I find half of the time I have to go look up stuff that I read a paragraph and I have to read it 5 times just to kind of get an idea of what they're trying to say, and then I have to go. Half of the time I have to get into the textbook and then start looking up stuff that they're saying within the paragraph, and it can take an hour to get through a page.
Oh yeah.
So,
100% understand that. So like the effects, the sympathetic surge, I think that makes perfect sense. If it's, blocking the reuptake of a neurotransmitter, then that neurotransmitter is just going to continue to build up, and then you're going to have this, hyper response to it. I think that makes a lot of sense.
Yeah, and it makes, that's what I've always kind of thought. But then when you read, there's other texts that'll be like, nope, we don't know how it does it. But then you read some other texts and they're like, well, this is how it does it. So I'm not 100% sure if the textbooks that I've been reading are right. Like they might come out and say, no, that's not exactly how it does. It creates that sympathetic response. But at least for now, in my mind, when I read what the books that I look at, that's how it's going to work.
Yep. And I've seen it as far as, you get that catecholamine surge, the heart rate climbs up, blood pressure maybe comes up a little bit. But that makes sense from what I've witnessed, things happening.
Yes. So, and we can touch on the catecholamine depletion type thing a little bit later. But if we want to go into the pharmacokinetics, sure. There's something that we learn about with drugs, right? And one of those things is called the PK, and this is where at a certain pH, 50% of the drug will be in one form and 50% of the drug will be in the other form. And it allows to go through membranes. So one of those membranes, the most important one being the blood-brain barrier. So when we look at ketamine, the PK of ketamine is 7.5, and that's at a physiologic pH. So that tells us that this drug is going to be highly, it'll cross membranes fairly quickly. So it's a highly lipophilic drug. So highly lipophilic drugs, or highly lipid soluble drugs, will cross the blood-brain barrier very, very, very quickly. So you have a drug that has a PK of 7.5 at physiologic pH, and then it's highly lipophilic. And that all in itself creates the scenario where the onset is super fast. And I'm sure you've seen it where you give it IV, it's within 30 to 60 seconds, it's working. And then you give it IM for somebody who's got some decent perfusion to whatever muscle that you injected that into, it's within a minute or two, maybe 3 to 4 minutes. I've read some texts, but when I've used it IM, you can see the effects pretty quick. Mm-hmm. And that's why. So usually if you inject it IV, the peak plasma concentrations occur within 60 seconds. And typically after IM injection, it's around 4 to 5 minutes. So when you get that peak plasma concentration, it's just concentration gradients. Like you have a super high concentration of this drug in the plasma or in the blood, and it then just goes down its concentration gradient. So the blood is going, so wherever the most highly perfused portions of the body are, that's where that drug is going to go, because it's going to go there first. Mm-hmm. So the brain being one of them. So it essentially just goes straight to the brain and goes down its concentration gradient. So there's a lot of it in the blood. There's none of it in the brain. So it just all goes into the brain. But once it leaves the blood, then the concentration gradient is the other way, right? So it's high in the brain, low in the blood. So then it just goes back. So into the blood, and it gets rapidly distributed to other tissues. So that's how ketamine stops working. It's not metabolism. It's not the metabolism through the liver that makes it stop working. It just simply gets distributed to other tissues very quickly, and it leaves the brain. So you'll typically, what I've seen is that even if I've like a 50 milligram IV bolus of ketamine, maybe 10 minutes, like it's short acting. And I don't think people appreciate how short acting ketamine is. Mm-hmm. And that's one of the things that I've learned over the kind of the years of using it is understanding that, like, you have to, if you're not going to do a ketamine infusion, you have to redose it fairly often to see the effects.
Mm-hmm, mm-hmm. How does that affect maybe? So that would be, I think, more of an IV dose would be like that 10-minute duration. What about like IM?
I think that all has to do with like how quickly, or how perfused that muscle is. Mm-hmm. If once again, this is a highly soluble drug, so it's gonna get into the bloodstream very quickly from the muscle. And once it's in the bloodstream, and then it's going to make it to the site of action, which is the spinal cord in the brain, or supraspinal, yeah. And very quickly come out of there back into the bloodstream and then redistribute to other tissues, and the effects are going to stop.
Yeah.
Now, have I seen super cold, and you get a patient that's been given a bigger dose of IM ketamine, and does it last longer? Yeah, it does. And I think that just has to do with there's less perfusion to those tissues, and it's almost like a depot effect, right. Where it's just the slower, the perfusion of those tissues is not as robust as somebody who's got normal physiology. So therefore it takes longer to get into the bloodstream, so that it works longer.
Yeah, no, I think that actually does make sense, because you're thinking about, somebody who's very cold or somebody who's hypotensive, their tank is essentially smaller than a normal person's. So
Yeah.
that drug, as it leaves, it leaves the brain or leaves the tissue to get back into the vasculature, it has less room to actually distribute. So it's going to take longer for that drug its effects to wear off, because that movement from the brain to the tissue is going to be slower.
Yeah, and that's something to think about too. Like if you have typically, let's just call it a 5-liter tank of blood, and you bleed out, a liter or two, now your tank is smaller. And when that happens, you tend to vasoconstrict and, protect, the body is like, what do I need to stay alive? Well, I need a brain. Mm-hmm. So blood's essentially cut off to everything else. So now you're pushing, the same amount of drug into a much smaller, liter, 3 liters instead of 5 liters. And then it's in a smaller compartment as well. So yeah, I agree with that. And I've thought about that too. Hence, you should give smaller doses to patients that are hypovolemic.
Right. So that would be that's kind of a perfect segue into my next question is, I think just about everybody I've met carries ketamine,
Mm-hmm.
but not everybody I've met has real practical experience using this relatively frequently. You see a lot of different patients from, people in like a walk-in clinic where they're getting some kind of, quick day surgery type thing, all the way to the very sick, the worst. How do you approach, this, looking at this patient, his vital signs, his, physiology as it is now, and dose ketamine?
Yeah, I think in general, like one of my instructors when I was in anesthesia school, he told me, he's like, everything that we give, whether it's an anesthetic gas, it's ketamine, it's something that makes the blood pressure go up, something that makes the blood pressure go down. For the majority of the medicines that we give, it's all poison. Mm-hmm. And you have to give the correct dose of poison in order to get the effect that you want. And everybody needs a different amount of poison to get the effect that you want. So if you treat your drugs like poison and you look at your patient and you go, if I give them this much poison, it's probably going to kill them. If I give them this much poison, it's not going to do what I want it to do. I have to give them the right amount of poison. So when we look at patients, we have to take into effect what's the surgery that is going to happen or is happening, or what is the injury pattern that I'm trying to treat. And then you have to kind of look at all of the comorbidities of whatever patient you're dealing with. Like, I think we always think that we're going to be taking care of some, 20 to 35-year-old super athlete. We might not be. We might be taking care of a pediatric patient. We might be taking care of a pregnant lady. We might be taking care of somebody who's elderly, who's smoked 60 packs a year or 60 packs a day or whatever. So don't always get into the mindset that you're only going to be taking care of some young, healthy patient that just doesn't have enough blood. So you have to take into account a lot of different factors when you're given a drug. You can't just, I think, and that's also one of the hardest things when I was in nurse anesthesia school is, the book answer. It's, 1 to 2 mgs per kg, and then it's 4 to 5 mgs per kg IM. And then, but you have a patient who's got, a blood pressure that they might not have radial pulses and their heart rate's 140. Are you going to give that same dose? Well, that 1 to 2 mgs per kg might be the lethal dose of poison that you're giving that patient, because they're in much different type of physiology than what you would give somebody who's just going to sleep to get their gallbladder out. So that person can handle 1 to 2 mgs per kg of ketamine because that's not the lethal dose for them, but it might be the lethal dose for a trauma patient. And I always try to tell people that I work with, yes, every drug has a book answer, but then there's the patient answer, and you have to see the patient in front of you and get an idea of like, all right, I should probably go a lot smaller and see what happens versus go big and then deal with those consequences.
So when you say a lot smaller, do you cut? So like the book, say the book answer, is kind of the book answer. Somebody who's really sick, that patient with no radials and, they're just sick. How much would you cut that book answer dose?
So let's just take a 100-kilo person, and we're just purely using ketamine. Mm-hmm. If we're just purely using ketamine and you have a 100-kilo person, so if and this 100-kilo person is coming in to get their gallbladder out, and you're going to just do an induction dose of ketamine, and you're going to do, let's say, 100 milligrams or 200 milligrams, I would most likely cut that dose probably almost by 75%. If I thought that this person was on the verge of losing vital signs, and I felt that they were on the verge of being catecholamine depleted, then I would use a much, much smaller dose, probably in the 30 milligrams to maybe 50, if at all. And just to not get into a scenario where now we're in PEA, mm-hmm. and the heart's beating, but there's no blood because we just vasodilated them out, or we knocked out their sympathetic tone, which is what was keeping them alive. Right. Because the statement ketamine is a myocardial depressant. That is what ketamine is. It creates a sympathetic surge, which is why you see an increase in heart rate and you see an increase in blood pressure, secondary to what we spoke about earlier, which is it prevents the reuptake of catecholamines. Mm-hmm. If there's no catecholamines to reuptake, then it is 100% a myocardial depressant. And that's where it becomes poison for a trauma patient. And you will give them a lethal dose of ketamine, because if you don't have a surgeon ready to cut open the chest and cross clamp the aorta, and you give that drug, and now you've knocked out their sympathetics, and they go into PEA, you're done. There's nothing you can do. You have to put blood back in them, but you're not going to be able to put the blood in fast enough. Mm-hmm. The surgeon needs to get in there, cross clamp the aorta, and essentially cut off the lower half of the tank from the upper half so you can fill the upper half with blood while they're trying to figure out where the hole is and to stop the bleeding. But if you're by yourself and you do that, like CPR does not work in a patient that does not have any blood. Right.
Before I go too far off, it's when you're talking about cutting dosing, so an induction dose, when I normally talk about it, I'm like, at least cut it in half. But you're saying even more is probably smarter.
Well, half is a good place to start, but if you're looking at your patient, I guess the question would be is can you stop doing what you're doing and just give them blood to try to tank them back up before you give them the ketamine? Yeah. So I'm giving ketamine in a scenario that there's literally a surgeon 6 inches away from me on my left-hand side.
Right.
And I have the answer to, we've just gone into PEA on induction. The answer is I have a surgeon that can get into their chest and cross-clamp the aorta while I'm dumping blood into them, where I think unless you have a surgeon with you, no one really has a good answer for that. Right. And unless you're some of our emergency medicine physicians are trained to do thoracotomies. I would have to assume our PA emergency medicine trained colleagues are trained to do this. But then the question is once you cross clamp that aorta, now what's your plan? Right. You've got less than 30 minutes to get to a surgeon because you have to get them off of that cross clamp. So the best thing to do is not put them into PEA by giving them too much ketamine. So start small. If you have an IV, it's easier, than IM. So if you have an IO, you can start smaller and see what happens versus giving like a big schwack IM. And then you're like, okay, you just bought that. Like there's nothing you can do about it.
Yep. Nope. Makes a lot of sense. I don't really know why you would, I guess, but maybe you're worried that this person could still feel pain and you need to do some painful things like a chest tube or a crike maybe. So you want to give them an analgesic dose. Would you would you reduce it roughly the same, half to 1/3?
No, I would imagine that if you had somebody that had some tension physiology and you were wanting to put a chest tube in, 10 milligrams to 20 milligrams of ketamine, I would imagine is going to be fine. And that analgesic dose, but once you give it, I mean, you've got minutes, not a long time to get your procedure done. They're still going to grow. They most likely will have a reaction to you making that incision and getting into the pleural cavity. But it's not as a robust response as if no ketamine was given. I mean, I've given 10 milligrams of ketamine to people with gunshot wounds, and they feel much better after that. And I'm just giving small doses IV just because I still want to continue to talk to them and assess them.
Yeah. No, very, very good. And you can always, if 10 isn't enough, you can always add a little bit more if you need to.
Yes, absolutely.
Yep. Perfect. So kind of on that note with analgesia, I kind of hear a lot of discussion about, when it comes to pain control, to analgesia, and people talking about, hey, ketamine isn't actually an analgesic, it's a dissociative. I guess I don't really understand what that means, because from what I understood, ketamine was a very good analgesic.
Yes. Ketamine, when you go back to the NMDA receptor and glutamate, and how the glutamate receptor is part of the pain transmission pathways, I would imagine, it's not just, it's dose dependent.
Right.
So the lower doses, you get the analgesic effects without the dissociative effects. And somewhere in the middle of that is where what we all know to call the party dose. It's where you get some of the analgesic effects and you get some of the dissociative effects, which create your party area where you can get some hallucinations and feel good. And then you get above the party dose, which is usually up into the 0.7 to 0.8 mgs per kg area. And then it's a dissociative with the analgesic properties.
Okay.
That's my understanding, and that's just from what I've read in my anesthetic textbooks. That's what I've learned. But I think you have to go back to the receptor. Where do those receptors live, and what do those receptors do? And if it's part of the pain pathway, then I don't see how ketamine could not be an analgesic.
Right, and that makes sense. From what you mentioned earlier about it hitting it. The NMDA is the dominant receptor it's targeting, but it is also hitting the mu receptors and other receptors in the spinal column. So you are actually taking care of pain. You're not just masking it with some kind of hallucination.
Yeah, and I guess I can give an example. I was taking care of somebody who had a gunshot wound, otherwise stable. Wasn't. Didn't hit anything major, but just the area that gunshot wound was an extremely painful area. And I was in a controlled environment. I wasn't out in the field. I was in a fixed facility, and I was working in fentanyl just to try to take care of this person's pain. And I'm, how I was, just here's 50 mics. Here's another 50 mics. And I'm just talking to him, just watching his respiratory rate, and just, asking him, where are you from? And just having a conversation with him as I'm working in this fentanyl. And fentanyl works very quickly, within, 60 seconds to 3 minutes, you start seeing some pretty profound effects. And I had gotten up to probably a dose that, most people would be uncomfortable with, but I'm just used to these big doses of fentanyl. But I was at 500 mics of fentanyl. Mm-hmm. And over the course of maybe 6 to 7 minutes, and it did not touch him. And I was just talking to him, and I'm like, did you get any relief from the medication I'm giving you? And I'm not telling him how much I'm giving him. And he's just like, no, man, it's 10 out of 10. And he's not looking like I'd given him anything. So then I'm like, looking at my vial of fentanyl, I'm looking at the expiration date. I'm like, nope, that's it. I'm looking at the IV. I'm like, no, that's definitely working. And I maybe it took the edge off a little bit, but not anywhere where he wasn't writhing. So I gave him 10 milligrams of ketamine, and the pain was gone.
Nice.
And he just said, I don't know what you just gave me, but I feel amazing. And I was like, cool, sounds good. And just, once that pain came back, which was about 10 minutes, 20 minutes later, just because that's how quickly it wears off, just gave him another 10 milligrams. And I stopped giving him opioids because they just did not touch him. And ketamine worked really well. And he was not disassociated. He was talking to me. He definitely was, he could tell that I had given him something other than opioids, but he was not, he could carry on a conversation with me.
Yeah. So speaking of kind of assessing your patient and wondering, where are they at? When you're looking at your patient and trying to assess, how well you're doing, what kind of feedback are you getting from the patient at an analgesic dose versus you starting to head into that party zone?
Well, that's hard, right? There's a lot of talk and kind of right now about Versed, midazolam, kind of being this evil drug, and it can cause all sorts of bad stuff in trauma patients. When I start getting into bigger doses of ketamine, the party dose, like 0.3 to whatever, 0.6, I think is some of what the books say, I start giving Versed. And once you give that Versed and you're into that party dose of ketamine, you really can't talk to your patient. I mean, it's just a different type of sedation. So, and I'm not talking big doses of Versed. I like a milligram, 2 milligrams, small doses of Versed. I don't go big on Versed. Most guys don't need a lot. 1 to 2 milligrams along with, 30, 40, 50 milligrams of ketamine is typically fine. That it's hard. You start seeing some nystagmus. They have that catatonic look. That party dose state, if you don't give Versed, I think you can start seeing somebody who becomes disinhibited, who's acting more, they're almost like somebody who's intoxicated. It's like you go from somebody who's got good pain control to somebody you're dealing with like that intoxicated patient who you just can't talk to somebody who's drunk, and they're just doing whatever they're doing. And it might take, a couple of people to hold them down. And then it goes into the dissociative and anesthetic, like you can do surgery on them. But I find that if you give Versed, you typically don't get into that, party dose reaction, even though you're in the party dose. That's just what I've seen.
Okay. So they're just kind of talking nonsense and kind of moving around a little bit, but they're not really interacting with you?
No, not that I've seen. I mean, I haven't been I've not been around anybody really that's just like, hey man, I'm going to party with ketamine. Right. It's just me giving them the wrong dose of ketamine and going, okay, I'm in the party zone right now. Okay. This is not good. Yeah. So, and I've seen people wake up from, I've given probably too much ketamine during a surgery. Not that they didn't need that ketamine. I just know that they were not narcotic naive. They had been on narcotics for a while for pain, and I'm trying to use a multimodal approach. So I give ketamine and they wake up and they're hallucinating.
Mm-hmm.
Some people, their hallucinations are fine. Like, hey, what do you see? I see this, that, and the other, or they're carrying on a conversation with somebody that's not there. But they're no harm to themselves and they're no harm to anybody around them. And they're like, okay, well, that's fine. That's going to wear off. Versus somebody who thinks they're back in combat and they're like, where is so-and-so? Where is so-and-so? That's the guy you got to give that Versed to, just to get them out of that hallucinations.
Right. And so I imagine just with as the drug kind of gets worn off, I mean, how long would that, say, for some reason you didn't have Versed, how long would you expect that kind of hallucination state to, because you're in an emergence reaction now?
Yeah, I've seen it last upwards of about an hour.
Oh,
yeah, I've seen it. The one person that I remember vividly who was having his trip, so to speak, or his hallucination was not bad at all. He was just carrying on conversations about motorcycles, and we didn't give him a bunch of Versed. We were just kind of letting that ketamine wear off, and I think it took almost an hour.
Yeah. Now, do you think it lasts? Because that's way different than the normal kind of metabolism or distribution, whatever it is, of ketamine. Do you think because it's so lipophilic, it just kind of got absorbed in the fat and it took so long to...
Yes, it could have also too. It is metabolized by the liver, and you've got it's through the cytochrome P450 enzyme system. Which, if you want to nerd out on that, we can. But you can have certain medications that will cause upregulation of that enzyme, and then certain things will cause downregulation. Mm-hmm. So the metabolite of ketamine is norketamine, and it's about third as potent, I believe, as ketamine. And then that's got to go through another form of metabolism where it gets conjugated, it gets hydroxylated, and then conjugated to form water, and then it becomes inactive, and then it gets excreted by the kidneys. So if that whole system of the liver type metabolism is not working correctly, and then your kidneys are not working correctly, then you could see prolonged effects. Now, with the gentleman that I'm thinking of, he was on a bunch of different medications, so I don't know if any of them downregulated the ketamine or the P450 enzyme system, or I'm not sure. It just seemed to, and he was a big dude, so it could have been that all the ketamine getting into his other tissues, it just created a ketamine sponge, so to speak, and it just slowly comes out of those tissues and then redistributes to the brain. And now we're in like the party zone as he's coming down.
Yeah. Oh.
And that was somebody that I did not use a lot of Versed on.
Right.
So I had given this person Versed up front, but by the time the surgery's over, that Versed gone. It's metabolized. But that ketamine, I continued to give him ketamine throughout the surgery because he needed it. And now he's waking up with ketamine on board without any type of long-acting amnestic on board, like Versed.
Okay.
So that's the scenario where you can get into, in what I've seen in the recovery room is people having issues waking up with ketamine.
Nice. Okay. Perfect. So another thing that I see a lot of medics talking about or asking me about that, to be honest, I don't actually know, is the catecholamine depletion thing. And so we kind of talked about, ketamine being a cardiovascular depressant. Now, like how how bad off does this person have to be where they're no longer making, epinephrine, norepinephrine?
Well, I guess the scenario that I would always imagine is if you have a service member who's out in a gunfight, their sympathetic nervous system is already fired. What have they been doing for the past couple of weeks? Are they getting sleep? Are they, it's just like, so are they already on the verge of, being chronically stimulated with the sympathetic nervous system, and now they're out running around with how much kit they have on, and now they're in a gunfight, and now they get injured, and now they're bleeding out. At some point, like, you're going to run out of catecholamines. Mm-hmm. When that is my guess is it's different for everybody. I've seen some patients come in where they are on the verge of losing vital signs. And if you choose the wrong dose of medication, you're definitely going to put them into PEA. If when you're inducing a patient and, their heart rate is 140, they don't have radial pulses, I would say that patient is on the verge of losing vital signs. They've reached the end of what their sympathetic nervous system can do. And for me, like, you might give 30 milligrams of ketamine, and then, your neuromuscular blocker, you put the tube in, you give one breath, and then you see your end tidal CO2 comes back at 10 or 20, you're in the trachea, then they've essentially lost vital signs while you were inducing them. Or is it the positive pressure ventilation that caused it?
Right.
So that's always the question I've had. Is it the drugs that I'm giving? Because there's the scenario where you don't give anything. You just give a neuromuscular blocker because that's how far down the pathway of shock they are. And then you put the tube in and they lose vital signs. That to me is just changing from negative pressure ventilation to positive pressure ventilation, and they've lost vital signs. Like, that's how close they were to losing vital signs before you change the pressure physiology in their chest. Mm-hmm. So, the answer depends. Like, if they, and it's hard too, like the scenario that I'm typically working in, like, I have, for the most part, white light. I can see them, where the scenario that your guys are working in, it's at night, it's dark, you're under nods. You don't have that feedback of looking at skin and seeing a guy that's, it's like pasty pale. It's not like it's that dusky color. They're not being perfused. That guy is probably catecholamine depleted, and you do not want to give a big dose of ketamine.
Yeah. No, that makes absolute sense. Is there any other, I guess, things that, if you could go back when you were learning, or would have advice for other medics who don't really get able to have the experience using these drugs before they punch out, what advice would you give, or cautions would you give?
Just what I had talked about before, and I have to remind myself, is that these drugs are poison, and the dose is very individualized. You can always give more. You can't take back what you've given. And when you're using these drugs, maybe for the first time in a real life scenario, if you have an IO or you have an IV, start smaller than what you think. You can always give more. So if we go back to the scenario that you talk about, like a chest tube, and let's say you give 10 milligrams of ketamine, and the guy's not tolerating, you put it in a chest tube. Well, that tells me that guy is probably being perfused pretty well. If he's got enough response to that surgical stimulus that he's moving, then really what you have to create is essentially not complete akinesia or complete not having him move, just give a little bit more, give another 10 milligrams. And if you get into the scenario where now you've put them in the kind of that party zone, have a plan for that. If that plan is to give 1 milligram of Versed, then give it. If they get into the party zone and it doesn't seem like it's bothering anybody, then you're probably okay to just leave them there and let it wear off. The other thing I would say just come into the OR with us. But the hard part is, I mean, we have tons of students. We do have medics coming through, but like the scenario that I'm giving ketamine a lot is they're already under general anesthesia. So you might see the catecholamine effects when, I could give ketamine, I can see like increase in heart rate, increase in blood pressure. Or the scenario a couple months ago, I gave a dose of ketamine to somebody who had an arterial line in, and we were bringing that person to the OR who had a vascular injury, but was otherwise doing okay, mentating fine. I was talking to him, and skin looked good. Like nothing about him told me that he had lost more blood than I had recognized, just because it wasn't external bleeding. It was all kind of internal bleeding kind of into his groin. And he was a thin person, but you didn't see this big hematoma. So I don't know if most of it went kind of retroperitoneal or where it went, but I believe I did induce with 100 milligrams of ketamine, and his systolic was 140/80 when I induced. And within about 30 seconds, his systolic was in the 60s. So there is somebody that had a lot less blood volume than I anticipated, or had recognized blood loss. And we used vasopressors to try to get his blood pressure up, and really nothing worked. I wound up giving him a gram of calcium chloride, and that ultimately got his pressure back to where it needed to be. So it's have a plan for when your patient definitely they're catecholamine depleted and you don't recognize it, and you're like, oh, that just happened, so I got to figure that out. Right. So I always tell the medics, like, you don't have the bag of tricks that I have in my bag, just because you got to be a lot lighter than I am. But you do carry calcium chloride, and calcium chloride is a very potent vasopressor for about 10 minutes. Yeah, perfect. So if you get into trouble with ketamine and you drop somebody's blood pressure significantly, think about using calcium chloride to get that pressure back up. Okay, perfect. So, and I think that's about it. Can't really think of anything else other than I would say definitely kind of be a nerd and dig into where that NMDA receptor is along the pain pathways and in the brain, and you get a really good idea of what ketamine does when you block those receptors. And I know you asked me this question about the seizures with ketamine. To be honest, I looked up using ketamine to break seizures, and I did not see anything that right off the bat. I think this is more of an email I'm going to have to send out to somebody who's got a much bigger brain than me, who's a PhD in neurobiology, and be like, hey, have you heard of this? Now, what I have read is that patients that have epilepsy, you can safely use ketamine in, so it doesn't induce seizures. But then some of the places I've read that it all depends upon what you're reading. It's like, nope, it is seizure-genic, and you're like, okay. It's like you don't know what to believe. So I guess the scenario, like you were saying, like I'm going to use Versed to break a seizure. Like I've got Versed, I'm using it. If Versed's not breaking a seizure, and I'm assuming you're moving towards some sort of a higher level of care, could you try to use ketamine? I don't know at this point. Like, I don't know enough about it to say that I would use it. I don't know. I would have to do some more reading before I went ahead and said, yep, I'll give it a shot.
Yeah.
I don't know. Yeah, I'm not going to lie. I don't know the answer to that question, or at least I don't have a good answer. And I haven't read anywhere that has said like, yes, like, somewhere down the line of your seizure, trying to break a seizure, that ketamine is somewhere in that algorithm. I just haven't read that yet.
Yeah. Now, the only thing I read about it had to do with, prolonged status epilepticus or some kind of refractory or drug resistant type of status epilepticus. But again, those are all kind of small studies, and you see a lot of contradicting information as well.
Yeah, and in that scenario, if somehow I am by myself in the middle of nowhere, I am typically not going to be in the same scenario that your guys are going to be in. I'm going to be with other people that have bigger brains than I do. But I would phone a friend is what I would do. I would be like, hey, this is what I got. These are the drugs I have. What should I do? If I was unable to phone a friend and like the only two drugs I had on me were Versed and ketamine, and somebody is seizing and seizing and seizing and seizing, and now I'm like, okay, I heard, Dennis and I talked and he said to try ketamine. I'd be like, I would have to have a good reason to kind of say, okay, yeah, I would definitely use it.
Right.
So,
well, the first thing they would be like is, who?
yeah. Well, that's the other thing that I always try to tell people is just like, I am not a reference. Don't be like, yeah, I spoke to that Kevin guy and he was like, yeah, do this. I always try to, like, if I give somebody a Tiva mixture or something, I always try to give them a reference. So that way, if they do it, they have an actual book reference, not some dude named Kevin.
Right. No, absolutely. Anybody, I think you trying to do analgesia or sedation in the field, I would definitely, at least at the minimum, look at the JTS or CPGs, and you got a lot of brain power built behind that thing.
Yep.
Cool.
Yeah, the CPGs are definitely what I go to when I try not to operate in the gray area. I try to stay within what the CPGs are saying.
Yep. Well, cool. Hey, thank you very much, Kevin.
All right. I'm sure I will listen to this and want to re-answer some of those questions like I did for the airway one. So I'll let you know.
No problem.
All right.
Cool.
Well, thanks, Dennis. Yeah, you have a good one.
For today's podcast, be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.